Welcome everybody to our webinar today, which is entitled What's New in PAH? Evidence from ATS, ERS, and CHEST 2023 for Improved Clinical Care. I'm Marty Gomberg-Maitland. I am the Director of Pulmonary Hypertension at the George Washington University School of Medicine here in Washington, D.C., and these are my disclosures. And I'm welcome Marius Hoper, who needs no introduction, but he is the professor in the Department of Respiratory Medicine at Hanover Medical School in Germany, and these are his disclosures. The learning objectives today are to describe the challenges associated with diagnosing and treating patients with PAH, including taking common comorbidities and concomitant drug therapies into account, to evaluate the clinical trial data, safety, and efficacy of emerging therapeutics for the management of PAH, to formulate treatment plans for various points in the PAH disease stages based on individual patient factors, and to identify strategies to effectively identify adverse events, optimize therapy, and improve outcomes for patients with PAH. So with that, I'll begin with the introduction and general PAH evidence updates from the three big meetings that occurred in May, this summer, and recently earlier this month in October. So first, the classification of pulmonary hypertension. These are some of the changes that occurred with the recent European guidelines. And, these always look complicated. It's really a bit of fine tuning. We still have five groups, group 1, which is PAH, group 2, which is PH left heart disease, 3, lung disease, 4, associated with PA obstructions, and 5, this multifactorial mechanisms. And what was sort of tweaked was that idiopathic became non-responders or acute responders for vasoreactivity testing. And we combined pulmonary, venous, and capillary involvement. We, in the PH left heart disease, made a preserved EF, and what here it says mildly reduced EF or reduced. It's really what we call, I think, heart failure with mildly reduced EF, or mid-range EF, and then our congenital cardiovascular conditions. With lung disease, we have obstructive lung disease or emphysema, restrictive lung disease, and restrictive obstructive, and then hypoventilation. And we made chronic renal failure with or without hemodialysis, thrombotic microangiopathies from cancers or tumors, and fibrosing mediastinitis. But for the purpose of today, we're going to be focused just on group 1 PAH. So here's our first polling question. We're asking you if you know the aims of the NIH NHLBI PVDomics initiative. Is it A, to augment the current PH classification based on shared biologic features? B, to perform comprehensive deep phenotyping across the current classifications groups 1 through 5? C, to use in-depth clinical information as well as genomic, proteomic, metabolomics, coagulomics, and cellular information for earlier diagnosis and personalized approaches, which is a lot of omics. And D, all of the above. Great. So it looks like pretty much everybody got the answer right, which is all of them. So PVDomics is 7 centers in the US. It's an NHLBI grant that extended, so we can gather more data and do the analysis. I was lucky to be on the observational monitoring committee from the beginning, and it's been a really long process trying to get sort of a head-to-toe data collection of all groups in PH. What I think was really interesting that was recently reported was the ground glass opacities that they found in group 1. So, this was based on chest x-rays. We're not really sure what the pathophysiologic and clinical implications are, but we wanted to see how often we see ground glass opacities in group 1 PAH. And what we can see here is that patients who had ground glass opacities tended to be less obese. They tended to have higher NT-proBNPs. They tended to be a little bit more on having hereditary PAH. They also had more portal pulmonary hypertension and pulmonary veno-occlusive disease. But I think what's also really important is that their right ventricular echo parameters and their right ventricular right-sided pressures, including cardiac output, were worse if you had ground glass opacities. And then this is showing us that actually they had a worse transplant-free survival. So, I think we all see that a lot of times these patients have ground glass opacities, but we weren't really highlighting it. And this is the first time that we're doing so. Marius, what did you think about this data?
It's fascinating. I always love these papers which analyze something that we all see, as you mentioned. We see this occasionally. Sometimes we don't really understand what's going on. Some of these chest CT scans look really crazy. You wonder whether there's some other form of lung disease ongoing, and now we start to understand. You said it's the first paper. In fact, a couple of weeks ago, a Japanese group published in radiology a very large paper also looking at these findings, especially the ground glass opacities, but also some other vascular findings. And very similar to what they found here in this PVnomics study was that it affects obviously mostly those patients with mutations. So BMPR2 mutations, other mutations seem to be commonly associated with these radiological findings. So phenotyping is becoming more and more complex, and certainly these chest CT findings play an important role.
Yeah, I mean, for me, it's impressive. I have a patient in the hospital that they kept reading having edema and pulmonary edema, but it's not pulmonary edema. It's there, but it's not what the issue is, and clearly it's not a good prognosis. All right, so we're up to the next polling question. Which of the following statements comparing methamphetamine-associated PAH to idiopathic PAH is not true? That if you have methamphetamine PAH, you're younger, you have a better socioeconomic status is B. C is that you present with worse functional status. D, you present with worse right ventricular dysfunction. And E, none of the above. The answer is B, that they have a better socioeconomic status. So I think it's, I'll be honest, and you can see on this map that based on my experience, I don't have a lot of experience with methamphetamines. I did when I was in Illinois versus when I'm in New York and DC. This is a study that was presented from the FAR registry data, which is the PH comprehensive care centers around the US, and that data set, and just looking at the incidence of patients that had methamphetamine PAH versus idiopathic PAH. And you can see it's really all west comparative to any other part in the country. And I would argue that the data is probably biased a bit, and maybe we're not testing enough in certain parts of the country, but it is instructive to see this. And what's not on this slide is everything that was in that question. What they found was that these patients presented at a younger age, had a worse functional class, had worse hemodynamics, and actually had more ER visits. And on top of that, they had more hospitalizations. And so when they looked at their socioeconomic status, and in the FAR registry, these patients most of them had public aid. So their insurance was paid by the government and had worse quality of life based on our quality of life measures. So it's clearly a different phenotype that we're seeing, at least in their presentation. This was another study that was presented, really looking again at methamphetamine PAH. This is a California group looking at their 200 patients. And what's important is this social determinants of health, or this area deprivation index, which is a multidimensional tool that quantifies the degree of disparities in a cluster of patients. And what they found was with these methamphetamine patients that they were seeing in California, that the ADI was higher, so that there was clear disparities in this patient group. And I think we're going to start seeing more sort of disparity studies in all types of PAH and throughout medicine, because we all know that it affects their outcomes. So this was an interesting study that's attempting to help with early diagnosis of the disease. It's really just looking at high resolution CAT scans, so non-infused CAT scans, and using AI technology to try to determine the size of the vessels. What this abstract showed was that the larger vessels correlated with the mean PA pressure and the pulmonary vascular resistance. The technology has the ability to look at smaller vessels and to also look at the venules, but this is not what the abstract was reporting on. But we're trying to get better imaging, I think, in the end, to move away from hemodynamics, but I think this is one of the ones where it's the first step into the technology. So moving on to new studies on current PAH treatments. So another question, which of the following therapies does not work on the same mechanistic pathways as the other therapies listed? A, iloprost, B, epoprostenol, C, riociguat, D, selexipag, and E, treprostinil. Yes, riociguat. All the others are prostacyclin-like analogs or derivatives working on vasodilatory pathways that are similar. So this is a breakdown of Mark Umbera's classic slide from 2004, New England Journal of Medicine, looking at the three pathways and showing what therapies are related to each pathway, or I should say target each pathway. So you have the endothelin pathway, we have ambrisentan and macitentan. In some parts of the world, they're still using bosentan. We tend not to use that due to liver toxicity. And because that was unpredictable and dramatic, and we have two therapies that are currently approved since then. Then you have the nitric oxide pathway, which is sildenafil, tadalafil, and riociguat, which is a guanylate cyclase stimulator. And then prostacyclin pathway, which is selexipag, iloprost, and treprostinil. You can also see what's available oral versus IV. The oral and IV are sildenafil and selexipag. Iloprost is actually inhaled, and it is IV in some countries. We should actually update that. And treprostinil is all three, oral, inhaled, IV, and even sub-Q. This is a slide showing the new evidence-based PAH treatment algorithm from the European guidelines. And what you can see here is that you have patients with idiopathic, heritable, or drug-induced PAH or PAH connective tissue disease. You want to be diagnosed at a PAH center and you want to have vasoreactive testing that's negative, because if it's positive, then they go to the calcium channel blocker aspect of this algorithm. But if it is positive, if it's negative, then you're going to go through these different measures, which you can see here is essentially differentiating whether or not you have any cardiopulmonary comorbidities, yes or no. And what we're highlighting here are the ones without, because those are the ones that we've been typically looking at. And we have not really signaled out whether you had current comorbidities that make you at risk for left heart disease or interstitial lung disease, no cardiopulmonary, and what's recommended based on your risk, low or intermediate versus high. And, this is one of these things where Marius is going to get into the risk stratification a bit in his part of the talk, but we're trying to get everybody to a low risk category. And we've clearly learned that more than one therapy is better than just one therapy alone in those patients without comorbidities. What's been discussed is that, and shown in some registry data, is that when we're using combination therapy versus monotherapy in patients with multiple comorbidities, we don't always get the same results that we would in patients without comorbidities. And that's what's going to be also discussed a little bit later. This is an interesting study. It is done really based on, I think it's 18 studies that were submitted to the FDA, and doing a meta-analysis of the individuals and looking at their different treatments to see how well patients did in their walk tests based on their treatment. And what you can see is that all patients compared to placebo did better, regardless of the pathway, but that when you had a combined pathway, endothelin and nitric oxide, so combination therapy, these patients had less clinical worsening and had more of a change in 6-minute walk. So it really confirmed what we learned in Ambition and what we've seen thus far. The ADIEU trial is a trial using a combined pill, macitentan plus tadalafil, and these results were presented, I think it was at ATS 2020 23 or maybe even before at no, it was ACC when it was presented, because Marius presented at ACC our sotatercept, and it was at the same meeting. This is a sub-study that was subsequently presented at ATS, looking at the change in pulmonary vascular resistance, and not unexpectedly, you saw that you got a drop in the PVR when you were on the combination compared to either alone, but it also depended on your age and your sex. So females, when you weren't of age over 65, you had a better response. And then here was the change from baseline based on functional class, which really was pretty similar, functional class 2 and class 3. So I think it showed that what we already knew, that if you're older, you tend to not have the same response than when you're younger, and that men typically don't respond as well as women. This is an interesting study, really retrospective, looking from the French group at initial dual oral combination therapy in patients with comorbidities, and looking at their changes in baseline and in follow-up, whether they were given monotherapy or dual oral therapy. And they just needed to have one cardiovascular comorbidity in the list of comorbidities. And what you can see here is that these patients clearly, they get a response on monotherapy and on dual therapy, but it's not as dramatic of a difference. Marius, what did you want to comment on this? Because I know that you think this is an important paper.
Yeah, I think this was one of the most important presentations on pulmonary hypertension at ERS. It is one of the hottest debates right now on how we deal with these patients who present with comorbidities. And comorbidities really are not that relevant. They just define a disease phenotype. It's just mentioned. We have patients who present with like a left heart disease phenotype that, despite having precapillary pulmonary hypertension, some have more of a lung phenotype. And these patients are in a gray zone. They're in a gray zone between group 1 PAH, group 2, group 3, something a little bit of everything. And the registry data that you just mentioned is suggesting that these patients do not respond as well to PAH therapy as patients with a classical phenotype, and especially when it comes to combination therapy, they also have a higher rate of treatment discontinuations due to side effects. So it's quite complicated. And here, data from France, they have one of the largest series in the world. They have a very good database. So they performed a retrospective matched pair analysis. And at least in that analysis, it seems that the patients with comorbidities, they seem to respond almost as well to combination therapy than patients who don't have these comorbidities. And the average age of these patients here was 68 years. So fairly old patients. So I think even if this is not a prospective randomized controlled trial, it's relevant data.
Yeah, and I think it's important because it shows that they definitely did better. I mean, when you look at the hemodynamics, the majority of the hemodynamics are better on dual versus single. And I'm going to guess that will translate over time to better outcomes, but we'll wait and see.
It didn't do it in that study. They had the survival data up to 10 years. In fact, they had a marginally significantly better survival at 1 year, but only at 1 year. But everything else was not significant, which is very similar to what we see with other patient populations. We have all these improvements here, but it doesn't really translate into at least clearly improved survival.
Yeah, I think we missed the days when patients were coming in their 30s, but it's definitely a different disease.
Absolutely.
So this was a study really just looking at patients who were treated with selexipag and looking at their risk assessment. And what you can see here is really that patients that were low risk stayed low risk, but that if you were of intermediate high or high risk, that your survival was worse even if you were on selexipag. It was a relatively small group if you look at the numbers of patients, but I think it was an interesting study to report on. So this is the Expedite study, which is also a small study. It's only 29 patients. And really what they did was they mimicked what we often do in clinical practice, where sometimes we start on IV prostacyclin and then we have an easier time switching them to oral because their bodies become adjusted to the different side effects. And so we can get to a higher dose versus starting oral up front. And what they found at 16 weeks is that most of these patients improved their functional class or maintained it, and their BNP improved. And like, this is all about 40%. And so things that you would expect if you're now getting a prostacyclin that you weren't on before. And then they also looked at the 4-strata risk model in these patients and looked at the functional class, the BNP, and the 6-minute walk distance changes, and found that these patients that started intermediate low then went to low. And so, we could have an entire discussion, Marius and I, on whether or not these patients needed to be on oral prostacyclin. But, I think we do want to get people to the lowest low that we can. I think it's a provocative study in that we know that we can do this, and it now shows people, maybe gives them more comfort to show that you can switch from IV to oral in a short period of time. I tend to not rush these kind of things, but nonetheless, it gives us some safety that you can do this. And this was a study using treprostinil inhalation power, and really looking in the BREEZE study, which was already reported. This is 51 patients, and they're looking at the median 6-minute walk distance at week 83. They did 2 analyses. They wanted to see if up titrating, how it correlated with the 6-minute walk distance, which is on the left-hand side, and on the right side, if their dose was greater than 64 versus less than 64. And as you would expect, with titration, your walk improves, and at a higher dose, you have a farther walk. And then finally, the Freedom EV. So this was the oral treprostinil study. This was the multi-center study, which was a placebo-controlled study, and the open label extension. And really what this was trying to show us was, hey, what happens with the placebo group, the ones that switched from placebo and then got drug? Was it as effective in that placebo crossover group? And what you can see here is that there were more deaths on placebo than oral treprostinil in the open label extension. And what they did was different statistics than what we've used before. And even as a statistician, I did not know what these were, so I will spell it out for everybody. The RPSFT estimates the survival time of patients on the placebo arm if treatment crossover had not occurred. And the IPCW is an estimate that centers patient at the treatment crossover and then reweights the remaining patients in the placebo arm by their inverse probability of not crossing over, which is always a lot of words when it comes to statistics. But what they're trying to do is not have survival bias and to really understand if the placebo group does as well. And what they saw was that the observed survival benefit was consistent with NT-proBNP functional class, even in the folks that were on placebo at the start. So, I think that they're really saying it doesn't matter when you start the prostacyclin, sometimes you're still going to get benefit, so don't just write it off. So with that, I'm going to pass this to Dr. Hoper. Marius, if you can start with the audience poll question.
It's already mine? Okay, I can do that. So the question here is, do you currently utilize a risk assessment tool in patients with PAH? And if so, which one? This is the most recent, so 2022 ESC ERS 3 or 4 state risk model, REVEAL. Is it the French non-invasive tool? Anything else? Or are you not using such a tool at all? Let's find out what you're doing. It seems to be a US-based audience, which is not surprising. So we have certainly REVEAL as the front runner here. And again, this is not surprising at all. And it's fine. It is fine. I think we do all now recommend using such a risk stratification tool for treatment decision making. Not as the only tool, but it's something very basic but very important. And there are several tools that have been validated right now, and it's just important to use one of those validated tools. All right, so let's see where we're going here. So studies on new treatments. So I take over here from Marty, who showed you the most recent evidence on studies with already available treatments or emerging treatments. So we're looking at really new compounds, new treatment targets now. And the first one is another important question here, which is, what is the mechanism of action for drugs like imatinib and seralutinib? Are they acting via the endothelin pathway, the nitric oxide pathway, the prostacyclin pathway, or the PDGF receptor alpha beta, so the platelet-derived growth factor receptor, and other tyrosine kinase pathways, or just the option is I don't know, which should be fine as well. This seems to be too easy here because the vast majority identifies these drugs as tyrosine kinase inhibitors, and this is certainly what they are. This story is not really new. In fact, it's about 10 years ago that this paper was published, and this is a phase 3 study, so already an advanced study with oral imatinib. Imatinib, as you know very well, is a fascinating drug. I think it was the first designer drug in cancer targeting CML, a well-known mutation there. And basically, it's acting on these platelet-derived growth factor receptors and c-KIT, which makes it potentially efficacious also in pulmonary arterial hypertension, as these pathways are involved in the proliferation of vascular smooth muscle cells. And here, the IMPRESS study, which I'm showing you, this phase 3 study, looked in patients who were pre-treated with other PAH medications, randomized to oral imatinib or placebo, and it found an improvement in the primary endpoint, which is change in 6-minute walk distance by about 30 meters. There was also substantial improvement in hemodynamics and other factors, including NT-proBNP. However, there was no signal towards an improved time to clinical worsening. There was quite a lot of drug discontinuations due to side effects, adverse events, and there was a fairly high rate of subdural hematoma. And at the end of the day, for these safety and tolerability issues, this development was stopped. Then at the same time, I think almost everybody noticed that there was a clear efficacy signal, and therefore it's good news now that this development is continuing, especially with inhaled compounds. With inhaled compounds trying to achieve a high pulmonary concentration of the drug, at the same time a very low systemic concentration. So minimizing the side effects by maximizing the potential effects of such a drug, it seems to be a logical mechanism. And several companies are now doing clinical trials with inhaled imatinib in the field of pulmonary arterial hypertension. One of the companies here presented their preclinical animal data at ATS, showing that in fact the lung tissue concentration of inhaled imatinib was much higher than that of oral imatinib, and at the same time, of course, as you would expect, the systemic concentrations were much lower. So overall, this seems to work in principle. So now we need to find out whether this is also effective in humans. And I think we will have the data from the first completed phase 2 study within the next couple of months. So this is quite exciting. What we already have is data from a phase 2 study with seralutinib. This is another inhaled tyrosine kinase inhibitor, also studied in patients with pulmonary arterial hypertension who have been pre-treated. And I'm showing you here the top-line results from the TORREY study, which was the phase 2 study here with seralutinib. Primary endpoint being change in pulmonary vascular resistance from baseline at week 24. And you see here that there was a significant improvement in PVR. It was about 1 Wood unit when placebo corrected. So it's not a dramatic improvement, but it's certainly statistically significant and perhaps relevant. And in patients who were sicker at baseline, the improvement was even a bit larger, although this was driven to some extent by a higher rate of worsening in the PVR in the placebo group. And we have also improvements, in fact, significant improvements here in NT-proBNP. But again, some parts of this placebo-corrected improvement were due to the deterioration in the placebo group. So once again, it's not really clear how much the efficacy of the active drug is really demonstrated by these data. In terms of tolerability, there were serious adverse events and severe adverse events that led to drug discontinuations, and especially coughing was quite common in these patients, also gastrointestinal side effects. Some as a Cortian nightmare, but it's more like vivid dreams. It's not very common, but it seems to be a unique side effect of this profile. The majority of these patients were able to continue this compound without any problems. And this is the data that we currently have. The company has decided to move forward to a phase 3 study now with inhaled seralutinib. And Marty, I just wanted to ask you how you feel about the potential of this and other tyrosine kinase inhibitors in our field.
Yeah, so Marius, as you know, I've been interested in tyrosine kinase inhibitors as long as you have, and think that it's one of the ways that we can target the vasculature and just the excessive overgrowth, just like what we do in cancer cells and cancer diseases. And it's nice to take compounds where we actually know the side effect profile. Here in the inhaled form, we don't. But I think it's good to see that we're trying new ways that target the lungs versus a systemic medication. But, you know, the thing about tyrosine kinase inhibitors is we never know what the off-target effects are going to be. And so we need to be cautious, and whatever studies we're doing, we need to have that long-term data. I mean, I think that it's exciting. It's nice to see that we have tyrosine kinases in addition to our vasodilator pathway studies all up and going. I think it's a race to see which works best, and that we have a lot to learn. And I'm looking forward. I had no experience with this in phase 2, but we'll be a site during phase 3. So we'll get to see how it goes. I think it's all positive.
Yeah, no, I agree. I mean, there's certainly potential, great potential, as we've seen from the IMPRESS data. Always the dream about this reverse remodeling, which is a potential option with these compounds. Let's find out. And there was a sub-study here presented at ERS from Tori, a fairly small sub-study, but fascinating. It's new imaging technology, CT imaging that looks at pulmonary vessels, which also without using contrast medium. And what they've done here is they have done quantifications of larger, medium-sized, and smaller vessels before and after exposure to seralutinib. And what they basically found here, I think there are some nice examples showing here on the left side placebo, on the right side active drug. There's basically no change or even a slight reduction in pulmonary perfusion of small vessel perfusion, in fact, without active therapy, whereas with seralutinib, you see, especially here in the upper part of the lung, there's more peripheral perfusion after inhalation of seralutinib. Of course, there was a heated debate whether this demonstrates reverse remodeling or not, and I think most of us agreed that this is not necessarily the case. It could demonstrate reverse remodeling, but it could also be just redistribution of blood flow. It could just be an increase in pulmonary blood flow. This alone could be sufficient to generate such images. So these images are beautiful, they're helpful, but we don't really understand for the time being what they tell us. And then we move on to the hot topic these days, which is sotatercept. And the question here is, what is the mechanism of action for sotatercept? Does it act via the endothelin pathway, the nitric oxide pathway, the prostacyclin pathway, the activin signaling pathway, or again, the fifth option is, I don't know. It's fairly new, but the majority is on the activin signaling pathways. And in fact, this will be the official term of this new class of drugs, which will be called activin signaling inhibitors. So this is how they will be called in the future, activin signaling inhibitors. This is brand new. So what is this? This is new. This is something we have never been used before. So sotatercept is the normal first-in-class fusion protein. It's composed of the extracellular domain of human activin receptor type 2A, which is linked to the Fc domain of human immunoglobulin G1. And it acts as a ligand trap. So it binds activins and other growth factors, growth differentiation factors that are involved in the pathogenesis of pulmonary hypertension. We have learned that the relative overactivity of activins is responsible for this proliferative component of pulmonary vascular remodeling. And we hope that by using these ligand traps, we bring back the balance to the system. And ideally with that, we won't be able to only slow disease progression, but again, reverse remodeling may be an option, because you can bring cells into apoptosis if you take away the growth factors. And this has been demonstrated in animal models of pulmonary hypertension. It's very difficult for the time being, in fact, impossible to prove that in humans. But still, what we have is data from randomized clinical trials. The phase 2 studies data have been published 2 years ago, and very recently the phase 3 data from the STELLAR study have been published. And in the STELLAR study, the primary endpoint was the change in 6-minute walk distance from baseline at week 24. And you see here that sotatercept in patients with PAH, most of whom had been pretreated with 2 or 3 compounds, 6-minute walk distance improved by about 40 meters from baseline. At the same time, we had very robust signals showing improvements of various other secondary endpoints, including a multi-component improvement endpoint, which is a composite of 6-minute walk distance, functional class, NT-proBNP. There was improvement in hemodynamics, NT-proBNP, functional class alone, also in clinical worsening, the French low-risk score, and 2 out of 3 domains of the PAH SYMPACT tool, which is a disease-specific quality of life score. And what we also saw in that study was an almost dramatic reduction in the time to clinical worsening here. You see here the blue curve. These are the sotatercept-treated patients compared to the placebo patients. And this was an 84% risk reduction with sotatercept. So the hazard ratio here was 0.16. This is really quite something. And at the same time, we have confirmed in that study something that we already knew from the phase 2 data, especially phase 2 open label extension data, that this compound had a very unique side effect profile. Sotatercept is well tolerated by the vast majority of the patients. In fact, serious and severe adverse events or adverse events leading to drug discontinuations were all more common with placebo than with sotatercept in this study. However, there were some adverse events that were certainly related to sotatercept and more common with sotatercept than with placebo, especially bleeding events. And this is mostly nosebleeds, epistaxis, and some gum bleeds. Epistaxis is something we know from other PAH medications as well, but it's certainly more common and caused by sotatercept here. We have the development of telangiectasia, similar to what we see in patients with cirrhosis, or sometimes also in patients with Osler's disease here. And we also have increases in the hemoglobin values, which is not surprising, as the drug was originally developed as a drug to treat anemia, certain forms of malignancies, and some thrombocytopenia, which is usually mild, and also some increase in blood pressure, which are also usually mild, but sometimes require treatment. So again, a very unique side effect profile. We have not so much in terms of side effects that led to drug discontinuations or treatment discontinuation, but nevertheless, it's a new compound, it's a new mode of action, and we have to be highly vigilant to see what is happening once we start administering this drug for 5 years or 10 years or even longer. And then at ERS, we presented for the first time data that looked in depth at the changes in hemodynamics and echocardiography in patients exposed to sotatercept in the STELLAR study. And this is really also quite fascinating data. Imagine you have a drug that acts on the pulmonary vessels, perhaps reopens or partly reopens these vessels by this anti- or reverse remodeling properties that we presume. And you have patients who had long-standing pulmonary hypertension. The average time from diagnosis to study inclusion was 8 to 9 years in these patients. And so, of course, they have severely remodeled right ventricles. So what happens with this drug is that there is no change in cardiac output, which basically remains unchanged, unlike most of the other PAH treatments that we use, but a substantial drop in the mean pulmonary arterial pressure of 13 millimeters of mercury. And this results in a substantial improvement in the pulmonary artery compliance, a reduction of the workload of the right ventricle. You see the unloading of the right ventricle by the drop in the mean right arterial pressure by about 3 millimeters of mercury, and also by a quite substantial drop in NT-proBNP. And on the echo, we see, consistent with the lack of change in cardiac output, there's no change in TAPSE. So tricuspid annular plane systolic excursion, a marker of right ventricular contractility, does not change. But the TAPSE over S-PAP ratio, so over the pressure, which is a well-established marker of coupling, which is extremely important for right ventricular function, improves substantially. And we see a quite significant noteworthy reduction in the right ventricular chamber sizes, so the right ventricle and diastolic and systolic diameter decreases, and so does the degree of tricuspid regurgitation. So we see a highly effective unloading of the right ventricle. And I wanted to ask Marty here how you feel about these data, which I think are very unique.
Yeah, I mean, I was extremely excited that we were able to provide this data because, the right ventricle is really the key, in addition to dropping the pressure. And we haven't done a great job in all of our previous trials really collecting this data. It's not easy, but I think it's the first one that shows that the right ventricle definitely is remodeling. It's getting smaller. The pressures are coming down even by the estimated pressure, but it correlates with the hemodynamics. And I think it's also nice to show the compliance, which we hadn't been showing before. I've never been a big fan of TAPSE because I find that it works well where the tricuspid valve is, but then the rest of the heart, it's not really moving very well. And they say, oh, it's a normal TAPSE, and it's not as reliable as looking at the actual volumes. And this is showing us that even if you don't get the volumes, but you just get TAPSE and the systolic pressure, you're getting similar results to actually measuring the volumes. And so I think that we're going to keep getting our imaging more precise and probably more programming in echo machines that will be able to do this and really see what's happening with the ventricle. I mean, it would be great if we could see what was going on in the vessel and in the heart itself, but I think right now this is the closest thing we have to it.
Thanks, Marty. Fully agree. I have two more slides on sotatercept here, and this is from the Soteria study, which is the study that catches all of the patients who come out of the phase 2 or of the phase 3 studies, so the complete Stella study, some of the ongoing studies. And this is 1 year data, so it's still not true long-term data, but we're getting there. And Soteria is going to continue for several years. So hopefully, finally, we have the long-term data that we need. And here, first of all, quite reassuring. After 1 year, we basically have no changes in 6-minute walk distance, NT-proBNP, functional class, or risk. So it seems that the majority of the patients is quite stable. And here, I don't want to scare you with this heavily overloaded table, but this is a summary of the side effects and adverse events that have been observed in Soteria after 1 year of exposure. So after 1 year of additional exposure, in addition to what has been used in the phase 2, phase 3 program. And I think there are some quite interesting and reassuring data. First of all, treatment emergent adverse events leading to treatment discontinuation. Here on the right side, all participants, just 6 patients, 1.5%. I think it's the lowest number ever that we had in the clinical trial so far. So despite the side effects I've been showing you, the patients stay on drug. Also, the number of serious adverse events related to treatment here is quite low, but this is an open label extension study, so this is something you would expect. Treatment emergent events leading to death. This is 4 patients, 1% of patients who died so far. I think the vast majority of these patients did not die from pulmonary hypertension. And then we had the adverse events that I have pointed out earlier, like epistaxis. This is 12% here. Telangiectasia is a bit more than 20% now. So it seems that with ongoing exposure, more and more patients develop at least some telangiectasia. Many of these patients is quite mild, but again, something that we have to just carefully watch. stay vigilant and see what's happening here. For the time being, we have no indication whatsoever that internal organs are affected by that. But again, it's just a couple of years of exposure, and let's wait and see what's going to happen after or with true long-term exposure. And then we're almost through with this lecture part here. Looking forward to the Q&A. So in summary, as Marty has presented very nicely, we have for many years now focused our treatment on three major pathways, which is the prostacyclin, the endothelin, and the PDE5 nitric oxide pathway. And despite the beneficial effects that these drugs have, we do not yet cure pulmonary arterial hypertension, and it will still be a long way to go there. It remains a fatal disease, but I think we are achieving something that one could call disease control in more and more patients. We have current guidelines that recommend to base therapeutic decisions on risk stratification using the 3 and 4 strata model or REVEAL, or some of the other validated models. Combination therapy is the name of the game. At least for patients with a classical phenotype, combination therapy, triple or double or even triple combination is state of the art. In patients who have significant cardiopulmonary comorbidities accompanying PAH, it is not yet clear, but there are emerging signals that I'll show you suggesting that these patients may also benefit from combination therapy. But these phenotypes, they definitely need to be further studied, especially the safety and efficacy of our drugs in these patients is quite important. And then, unfortunately, after 10 years or so of more standstill than advancements, now we have emerging therapies that are very likely to expand our therapeutic armamentarium and will change the management of patients with PAH. So then I stop it here for the presentation, and we can go to the Q&A.
Yeah, so we have a whole bunch of questions.
I see that.
So I'm going to start with the first one for you, Marius. Is there any research that's actually specifically looking at mitochondrial dysfunction? Because we know it's involved in the pathophysiology of PAH. And do you know of any trials that are, or anything going on to look at this pathway for reversing the damage?
Yeah, the question is excellent. It's true. For many years now, several group of researchers have been focusing on these aspects, and there's some kind of hope has been built around the targeting this pathway, the mitochondrial function in these patients. To the best of my knowledge, there's only a small published study so far, and this study did not show clear efficacy signals. I'm not aware, Marty, maybe you know better in your side of the world, that there are any larger studies targeting mitochondrial function ongoing right now.
Yeah, I don't know of any. I know that we've done a lot in the animal models, but I don't think we've actually translated it much to patients. It doesn't mean that it won't happen. It's just that sometimes you just need to have the drug before you can then pursue the target, right? Otherwise, it's hard. We can come up with a lot of different pathways that are implicated in the disease. In fact, we have hundreds now. And how do we know what to choose? Some of it's based on what's already developed. I'll answer the second question that we had here, which on risk stratification tools, is one better than the other? I think that for me, I don't really care which you use as long as you do something and you do it consistently. I think it's really important to not just use Gestalt, as we say, that the patients like to have the hard data as well, but you also need to be consistent. I think that the REVEAL Lite 2 is the most statistically sound as far as like giving clear differentiation, but that's not always what you need in clinical practice. So I think it's really just your own preference and what you can do. I can say that all throughout Europe, they're using the risk strata 3 and risk strata 4. Probably should be just using risk strata 4 throughout to get you the most detail. But again, it's doing something instead of nothing, and really watching your patients closely and not just giving them a medication and seeing them in a year.
I agree with all you said, Marty. Do you also want to comment on the next question on the sex paradox that we have in PAH?
Yeah, I mean, I think that we haven't really figured out why men have worse prognosis than women. And we assume that some of that is estrogen. I don't think we've actually pinpointed it. There's a lot of different studies looking at this in small phase 1, phase 2 trials trying to target hormones. I think it gets tricky. Hormones are tricky because they don't always just work in one area in the body. But the group in Rhode Island, Corey Ventuela, is really eager to try to find something that will help us. I think it's too early to say, but I definitely think that there is something that makes women more at risk than men, for sure.
Yeah, that's true.
I can comment on the iron deficiency, which is, can you comment on iron deficiency? And there are clinical trials investigating the role of iron supplementation in heart failure, which it was shown clearly had a benefit. We have been checking iron studies in patients even when their hemoglobin looks in the normal range, because frankly, if you're hypoxic, I'm not sure that it should be a hemoglobin of 13 or 12. It's probably kind of on the higher, like it should be probably higher than that if you're on supplemental oxygen. And we often do unmask iron deficiency. So I think that as far as doing a clinical trial with it, the more therapies that we have, the harder it is to show that there's a difference. But I do think it's something that we should check. And I know that in the PVDomics data, they uncovered that many of the patients were iron deficient. So I do think it exists, but I don't know if we're ever going to be able to test it. What do you think?
I think the iron story, I mean, probably has been a bit blown up for some time. Iron is important, iron deficiency is important, it needs to be correct, that's for sure. I'm not sure if we will ever generate data on iron deficiency without anemia. I mean, the two studies that have been published, very small studies, have been negative, but probably underpowered, so it's difficult. I think we all agree once there's iron deficiency and anemia needs to be corrected, everything else is unknown.
So there's a whole bunch of sotatercept questions. So I'm going to highlight a few, which is, have we seen anybody on a long-term basis develop AVMs to date? And the answer
not yet.
No, we have not.
Not yet. No.
So we should say that for sure. No, we have not. Yeah. They want to know, sotatercept, when it's approved, which patients would benefit the most from the drug?
It's certainly something we don't know. I mean, certainly those patients that have been enrolled in the PULSAR data studies, so relatively young, mostly female patients with idiopathic or irritable PAH, that's for sure. There were relatively few patients with connective tissue disease associated pulmonary arterial hypertension in these studies. So it's a little bit of unknown yet, but there are two ongoing phase 3 studies with sotatercept called senescent hyperemia. Hyperemia is mostly in patients who have relatively recently diagnosed PAH. Senescent are patients with very advanced pulmonary arterial hypertension, and there are more patients with CTD associated PAH there. So there will be data, that's for sure.
Yeah,
I like, if I may continue, I like the question about how to explain why it acts so quickly. And it really acts quickly. What's really not in the papers, a significant effect on NT-proBNP can be demonstrated at week 3, which is 3 weeks after the first injection. So it acts quickly. And some people say, oh, this is surprising. This can't be an anti-remodeling effect. In fact, yes, it can. Because if you work in cell cultures and animal models, and if you use these anti-remodeling strategies just by taking away growth factors, you see changes within 24 hours. You see apoptosis within 24 hours. So it's absolutely plausible that you see effects after a few weeks of therapy. We had very, very similar things 10 years ago with imatinib.
I was going to say, when we see it all the time in left heart failure, we get the ejection fraction improves quite quickly. There's probably a bunch of different mechanisms going on too, as far as what the RV is doing. We haven't really looked at stunning of the RV or hibernating RV, right? We can get into a whole new area of research at what's happening to the ventricle, which is fascinating and makes me happy. They want to know which are the comorbidities that we've been talking about. And I think that's best answered by you when you're talking about the cardiovascular comorbidities. What were your groups in your study looking at cardiovascular versus cardiopulmonary?
Yeah. Two phenotypes. I mean, the pulmonary is easy. Smokers with a low diffusion capacity being less than 45% of the predicted value, they have a distinct phenotype and they probably have a distinct pulmonary vasculopathy. The left heart phenotype is the heart failure with preserved ejection fraction phenotype. It's mostly elderly patients with a history of hypertension, diabetes, often obese, often coronary heart disease, and these patients also on echo, they have signs of diastolic dysfunction. They have a dilated left atrium. You do the cath, it's precapillary pulmonary hypertension. This is why we call it PAH, although many of us are uncertain, which is if it's truly PAH or if it's not just disguised group 2 pulmonary hypertension. And this is the gray zone that I mentioned. It's sometimes basically impossible to decide whether this is a PAH patient or a patient with HFpEF and combined post and precapillary pulmonary hypertension.
Yeah. And I think that there are a lot of comorbidities that are not included in these that have clear significance. And so I think as the next few years, we're going to probably have to sort of redefine comorbidities and what's important, and try to even further phenotype. Because, I mean, we all know that renal disease is a poor prognostic factor even at diagnosis. And so doesn't really fit either category, but it's not a good one to have.
No, but this is true for any disease.
For any disease, and you know what? The more diseases you have, the sicker you are. That's what it is in medicine.
It makes sense. And with that very brave remark, I think we are 30 seconds away from the hour here. Thank you very much, Marty. Your participation here was great, was wonderful. I very much liked your presentation. You had the more difficult part, I believe, and thanks a lot.
Thank you, Marius.